Thank you so much, Dr. Lemon. Thanks all of you for your attention. I'm going to make this very brief. If you've been to the VQI at VAM the last number of years, you've heard me talk a lot about ERAS, and I'm very, very excited today to have other people starting to share the message and to become experts in this area as well. The work that we've done together on the ERAS writing committee has been really rewarding, and I think it will end up being really impactful for the quality of the care that we provide to our patients. And I'm very excited that the VQI specifically has inserted itself into the process of figuring out how to measure adherence to ERAS process measures. As you'll learn through the next talks, there's about 30 to 40 different things that correlate with about 100 different process measures that can be measured. Obviously, in the VQI, we're not going to have all of you ticking off all these millions of boxes to make the registry unwieldy, but what we would love to do is have centers who can measure their adherence to the ERAS guidelines linked with their patient profiles in the VQI. So eventually, over time, we can figure out if our outcomes are actually improving related to our adherence with ERAS, and that will help us figure out which of the components is the most incrementally important. And then just to tag a little bit onto the previous talk, the patient expectation setting, no matter what the operation is incredibly hard to measure, but I would argue the most important thing that we do. And remembering to include the patient in the multidisciplinary discussions so they can actually be an advocate for their own recovery and participate in their post-op care instead of laying in the bed passively waiting for other people to come along and help them has made a lot of improvement in other surgical specialties, and I look forward to seeing that in vascular as well. So hopefully next year more details to come on formal relationships between the VQI, the SVS, and the ERAS Society. But in the meantime, I'm going to turn it over to my two friends and colleagues to give you an in-depth look at what the ERAS aortic guidelines are. These are the ones that were just published in JVS, and then also a primer on how to get a program started at your institution for vascular. Thank you very much.
Good morning. So, well known to this room, surgical outcomes reflect more than just intraoperative care. Enhanced recovery after surgery, or ERAS pathways, have been applied in other surgical disciplines and are associated with decreased lengths of stay and reduced care disparities. We'll go over a little bit of the ERAS history and principles, as well as more details and highlights of our aortic guidelines. The concepts here are new in vascular, but are not objectively new. The first publication surrounding the concept of multimodal surgical care that set off the concept of ERAS was published by Dr. Kellett in the British Journal of Anesthesia in 1997 and laid out that the idea of modifying the components of the surgical stress response could improve recovery and reduce postoperative morbidity. From 2001 to 2004, a perioperative ERAS study group in Europe was formed that developed many of the early protocols within colorectal surgery. And it's worthwhile noting that when you think about this time frame, that's also when a shift from open aortic surgery to endovascular aortic surgery was occurring domestically. And that may be why a focus on reducing the perioperative stress of open surgery was not as great of a focus for vascular surgeons, as we had a more minimally invasive option that was coming to be in clinical practice. In 2005, publication of the colon surgery ERAS guidelines were put forth, and within the years following, expansion to rectal surgery. After that, a formal nonprofit medical society of the ERAS Society was developed, and there's been progressive spread throughout other surgical specialties, with cardiac surgery in 2019 and our vascular guidelines being published this year. Upcoming guidelines surrounding less elective and more emergent general surgeries are in development, as well as those for cytoreductive and upper GI surgery. And the ERAS website in general has resources that spread broadly for anesthesia, nursing, and allied healthcare providers across some of these different specialties. When we think of ERAS principles, it's extending throughout the arc of care from preoperative through postoperative. In the pre-admission phase, a focus on risk stratification, patient optimization, and education and expectation setting. In the perioperative and intraoperative phase, attenuating the surgical stress response. And in the postoperative phase, maintaining postoperative physiological functions back towards baseline as soon as possible. A note on terminology, that when you see ERAS with a trademark, that indicates that it's an enhanced recovery after surgery society endorsed statement or protocol. ERP, or enhanced recovery protocols, are those that are not necessarily ERAS society endorsed and may be common for individual institutions to create on their own. A term used more in the past but less currently is fast track. There is potentially a distinction in some of these fast track protocols that they weren't necessarily multimodal or transdisciplinary in approach in all cases. And so there's been a progressive shift in emphasis away from this term towards enhanced recovery, emphasizing that we aren't as concerned with the speed of recovery, but more the quality of care along the trajectory. And pictorially, you can think of this a little bit as if you have a tortuous race course that experienced race drivers may be able to navigate it fast, but the majority of people would have to proceed more slowly through that course. Whereas if you're able to straighten out the track and remove obstacles, more people can extend from the start to finish in a more rapid manner. So with that foundation, I'd like to introduce the SVS Open Aortic Vascular Surgery Guidelines, and particularly acknowledge that the author set for this was comprised of vascular surgeons, anesthesiologists, PAs, and NPs from an international scope. When we look at the concept of the ERAS guidelines, you'll see that it's multiple interventions across all phases. In the preoperative phase, we're focusing on optimization. In the intraoperative phase, on stress minimization. And in the postoperative phase, more protocolized efforts at normalization. Throughout all of these, there remains an emphasis on patient education and counseling, as well as the importance of auditing and evaluating outcomes across all phases. So focusing on the pre-admission timeline, first, it begins with patient information education, and particularly to highlight that this should be both verbal as well as written. Then more standard recommendations for risk factor screening, although noting in particularly the issues of frailty and delirium that may not have been previously part of general anesthetic evaluations. Lastly, in terms of optimization, what we can do to make identified problems better, understanding the concept of prehabilitation as structured exercise therapy for up to 6 weeks before purely elective cases, not something that would necessarily delay more urgent care. And then lastly, thinking about the perioperative period for medications that require more than just immediate perioperative holds, the recommendation that aspirin be continued throughout, but that secondary antiplatelet agents and anticoagulation be held based on their half-life time course, except in special patient populations, to further allow use of multimodal analgesia with adjunctive blocks at surgery. In the preoperative phase is where more of the newer concepts to vascular care reside. So far, many of these have been abstracted from other ERAS protocols of major abdominal surgery and more recently implemented in the cardiac surgery guidelines. Therefore, future vascular-specific evidence base will need to be either developed or validated going forward. In particularly limiting the duration of fasting, using carbohydrate loading, and multimodal pain control are the newest elements. In limiting fasting, it's a shift from NPO after midnight, regardless of time of operation, towards avoiding overnight fasting and encouraging clear fluids for up to 2 hours before surgery and light fluids for up to 6 hours before surgery. Heavy food is still discouraged for at least 8 hours before surgery. On the carbohydrate loading, our recommendation here is specific to patients without diabetes, that they should receive a preoperative carbohydrate drink. And what is meant by that is 800 milliliters of a clear 12.5% carbohydrate drink the evening before surgery and up to 400 mLs of the same up to 2 hours before surgery. And it's proposed that this modulates the inflammatory and metabolic response, reduces postoperative insulin resistance, and results in less perioperative hyperglycemia than either placebo solutions or NPO after midnight status. While our recommendations currently do not extend to non-diabetic populations, early results within cardiac ERAS programs where patient cohorts have been up to 60% diabetic patients have demonstrated no difference in postoperative hyperglycemia within the first 24 hours in diabetic versus non-diabetic patients receiving carbohydrate loading. As far as medication therapy goes, from an anesthetic side, appropriately controlling nausea and vomiting and avoiding use of sedatives, but newly encouraging use of acetaminophen, NSAIDs, and gabapentinoids as part of a multimodal strategy to reduce opioids, with the caveat that NSAIDs and gabapentinoids may need to be dosed or avoided based on age and renal function. For venous thromboembolism prophylaxis, open aortic surgery does still have a substantive DVT risk to it. And so the recommendation is to routinely use calf-length intermittent compression devices combined with prophylactic doses of unfractionated or low molecular weight heparin. This should be started immediately before surgery and continued at least throughout the hospitalization, with immediately before surgery meaning after block placement and subsequently requiring a managed hold around epidural removal. Much of this data derives from mixed populations, and there can be concerns about intraoperative bleeding. Therefore, if the consequences of bleeding are thought to be severe, we encourage use when risk abates postoperatively. Antimicrobial agents should be used as currently recommended by SBS aortic guidelines and stopped within 24 hours postoperatively. From an intraoperative anesthetic and medication protocol, we encourage use of neuromuscular blocking agents, cardiovascular monitoring, cell salvage, and lung protective ventilation. In addition, for purely infrarenal repairs, the medication use or ischemic preconditioning intended to be renal protective is discouraged. If there's a suprarenal clamp, then these recommendations do not have the evidence base. And finally, the epidural anesthesia placed perioperatively is considered to be a key adjunct towards limiting opioid intake and modulating the perioperative pain response. Additionally, for infection prevention, maintaining normothermia, and avoiding routine use of drains to the surgical wound. Multimodal analgesia we encourage to be maintained postoperatively as well. And then some of the more potentially contentious recommendations include avoiding routine use of postoperative nasogastric tubes. The evidence base for this comes in large part for cases such as in the pancreaticoduodenal ERAS protocol, where they're mobilizing the duodenum, that they recommend removal at the end of the case. In previous literature, elective AAA repairs have a median duration of return to gastric emptying within 18 hours plus or minus 7 hours after surgery, so it's thought that this can successfully occur and has been shown feasible in fast-track studies to date. As far as oral feeding, we encourage to not intentionally restrict solid food intake after 24 hours, that while this should be more of something that patients could choose for comfort what they're willing to trial afterwards, not necessarily that you're forcing someone to have a cheeseburger postoperative day 0. As far as urinary drainage goes, we encourage early removal of urinary drainage catheters, and while this might seem potentially in conflict with use of thoracic epidurals, that in the general population, the rates of urinary retention requiring replacement of a urinary catheter are only about 10%, and even among men with BPH, the rate only rises to about 25%. And that this can be a successful adjunct in helping to limit number of tethers that prevent patient mobility. Glycemic control is encouraged as well. For early mobilization, having a formal plan for mobilization and assessments that are occurring twice a day with early physical therapy involvement when needed is recommended. And finally, towards patient discharge education, having again both verbal and written communication for the patient, as well as arranged appointments as suggested, and ongoing audit of outcomes and elements throughout, and checking in that appropriate stakeholders and involved parties receive feedback. So some of that may be very familiar, and some of that may be very scary. I would encourage that not all recommendations have aortic-specific evidence base available, and that we've extrapolated from most appropriate adjacent populations where feasible, and that uptake does not need to be all or nothing. In other ERAS protocols, there has been an association with increasing number of elements used associated with decreased complications and length of stay. But in that goal of modulating the stress response, improving patient understanding, and having protocolized normalization, even some of the elements are likely to have a benefit compared to not doing them. And finally, a protocol alone is not enough. In other studies, merely having a set of guidelines and putting them on the wall does not lead to change in outcomes. It has to be something that has multidisciplinary care buy-in and audit of outcomes. And I'll leave it to my other panelists to discuss in more details methods of implementation and proposed future audit outcome assessment. So in conclusion, enhanced recovery principles and structured protocols have been successfully utilized in other major abdominal and cardiac procedures to improve quality of care delivered and outcomes. The SVS documents on ERAS outline available evidence for this in our newly published aortic guidelines and upcoming lower extremity bypass recommendations. And we'd be happy to field more questions later.
Good morning, and thank you for the invitation to talk about implementing ERAS at your institution. I have no disclosures. So I will touch briefly on what enhanced recovery is, although Dr. Spengler has provided an excellent overview, so I won't go into any detail about that. I'm going to spend a lot more time talking about how to assess your readiness for implementing ERAS, how to garner support, some of the concepts that I think are helpful for successful implementation, including overcoming resistance. So compared to traditional pathways, we know that enhanced recovery is a protocol aimed at improving outcomes and patient satisfaction after particular vascular surgery, in this case, procedures. And there are some novel elements that are different from the way we normally take care of our patients. For example, Emily mentioned that instead of making patients NPO after midnight, in many of the pathways that have been published, there's excellent evidence to support letting patients drink clear liquids up to 2 hours prior to the surgery and including a carbohydrate load prior to that 2-hour window. But a lot of enhanced recovery really just aims at trying to streamline existing processes and then shifting the timeline of the traditional pathway. So similarly with regards to diet, instead of keeping patients in PO after surgery and then advancing them from clears in a slow fashion on post-op day 1, our patients in our particular pathway get a diet right after surgery, clear liquids in the PACU, and advance is tolerated. So there's some definitely concepts that I think are difficult for implementation with regards to buy-in, and we'll talk a little bit more about how to overcome that. Institutions who have implemented enhanced recovery have shown improved outcomes, and as Dr. Spengler mentioned, there are a lot of different specialties that have published great results after implementing enhanced recovery. And vascular surgery is a little bit late to the game, but I do think that since our patients are older, frail, and are increased risk for complications, it makes a lot of sense for our patients. In our particular experience, we implemented an ERAS for lower extremity arterial bypass, so I will reference that specific pathway throughout the talk just for examples. I do think if you are thinking about enhanced recovery, there are a couple different questions or concepts that you should consider to assess whether you think you're ready or not. Just like all QI efforts, it takes a team. But you really should have a very strong champion. Frequently, that's a member of the vascular surgery service. I think knowledge of your patients and your care pathway is essential. But there's also a real benefit to having someone who has a lot of knowledge about quality improvement and specifically enhanced recovery. So pairing with, say, an anesthesiologist or someone from the perioperative services team who's been involved in other enhanced recovery pathways as a co-champion makes a lot of sense as well. And given the complexity of the intervention and the timeline, so for example, from the time we first met to talk about what our pathway was going to look like from our go-live date, it was a little over a year. So it takes a lot of time to get to that phase where you even start implementation, and you really need to keep that momentum up. So having a coordinator, someone who can have some experience with project management and can help with the process of communication and stakeholder engagement is really, really helpful. So if you have the resources for that, I definitely would recommend it. And someone from process improvement is a natural selection. Then you have to think about which procedure you want to focus on. I think first, and at a minimum, you have to have data that you can review to determine if there's opportunities for improvement in your outcomes. And VQI is an obvious source of that data. So if you already participate in the aortic module or the lower extremity bypass module or amputation module, and you know that your patients could benefit from an improvement in their outcomes, then that may be a first step in determining which procedure makes most sense for you. The other thing to consider, though, is your annual volume. If you have a very low volume of the procedure, then it can make the momentum needed for really affecting change very challenging. And it also may take time for you to assess results. And you want to get that immediate feedback to help keep people on board and celebrate change early on in the process. So if you have a higher volume procedure with opportunities for outcome, that's ideal. And then finally, in this particular question, considering the complexity of care can also be helpful. For example, our first procedure we considered was lower extremity amputation, major amputations. But as is mentioned in some of the earlier talks, our patients with amputations are often admitted to both vascular surgery and the medicine service. And when you try and do a quality improvement project, would you have multiple services, increasing the number of stakeholders, that can increase the number of barriers you have to implementation. So we landed on lower extremity bypass. Obviously, we have a lot of improvement in multiple areas, opportunities. So we had other procedures we could focus on, and those patients were primarily housed on our vascular surgery service, which made it a little bit easier for implementation. And then finally, you should consider whether other services in your institution have implemented enhanced recovery and what their experience has been. So talking to those folks who have already successfully implemented enhanced recovery and determining what the resources are that are available and what barriers they've faced can be extremely helpful. So then once you've considered all these factors, you can determine, are you ready to launch, or do you need some time to build resources, data, and engagement in order to make your effort successful? And there are lots of different approaches. If you think you're ready for implementation, there are different methods that are common to quality improvement, DMAIC, and PDSA cycles. But I do think that this Cotter's 8-stage change model can be helpful because it both incorporates the classic QI methodologies and all of the change management principles that I think are key to establishing buy-in for a complex intervention. And I'll provide an overview and then go through each of the steps and talk about how they're relevant to enhanced recovery. So the first part is really trying to ready your team for change. So you gather the data that you need to help convince people that change is what's in their best interest. Then you create a team, and that team together forms a shared vision of what change looks like. And then the next phase, you essentially communicate that shared vision to various stakeholders that you think will be implemented or affected by the change. And you not only communicate what change will look like, but you communicate what success will look like and how often they should expect feedback and how they provide feedback to you. And then in the final phase, you use a set of measures that you've developed based on your shared vision, and you track those. And you use those to both celebrate early wins and then finally to determine what opportunities for change that you have in your pathway, and you combine the measures with stakeholder feedback to make iterative changes in the process as you go forward. So when you're creating a sense of urgency, a lot of people talk about establishing a Bernie platform. And it essentially is an argument that makes people feel like the status quo is a non-option. However, I feel like that's a little bit of a strong arm approach in some cases, and you may need to coerce people rather than push them into change. So sometimes it's helpful to think about a compelling story that appeals to the values of their stakeholders, like doing the right thing for your patients, or to their personal interests, and whether that's cost savings or time savings. So having an established pathway that works well will be more efficient and make it easier to take care of patients, which ultimately will make it more satisfying to care for patients for the people who are providing that care. Then you build your coalition. In our experience, we plan to do enhanced recovery over 3 hospitals in our system. So we created a group of vascular surgery representatives from each of those 3 hospitals, plus some quality and process improvement people. And we created a draft pathway based on the phases of care that Dr. Spengler reviewed. And as she mentioned, there are no endorsed pathways for vascular surgery at this time, particularly not for lower extremity bypass. And so we combined components of existing ERPs from other services with the literature for vascular surgery and sometimes committee consensus to come up with a pathway. Then we basically created work groups over those phases of care. So we identified people that would be involved in that process, key stakeholders in the preoperative, perioperative, and postoperative phases, and we asked for them to review the pathway. We had a series of meetings where they talked about the elements, we reviewed existing processes, and then identified opportunities for improvement and resources that we might need. And there was a fourth group of stakeholders that we didn't really establish work groups with, but we engaged early. As you can see, this list is not those that are relevant for the clinical component, but they're nevertheless essential to your success, particularly if you're going to ask for resources. Once we finalized the pathway based on those work group feedbacks, we reviewed it and considered a couple of key things. Are there existing processes that we do already that we can just improve upon? And then if there are changes that we're going to make, how can we prioritize those? So including a lot of changes can be associated with improved outcomes, but you don't want to burn your team out really early. So some of the things you can do if you're considering a lot of change is to phase the implementation. So you can limit it to particular surgeons. If you have very engaged early adopters, that you can say, okay, we'll just do the ERS for your patients. That might be one approach. You can also limit it particular sites. Like we decided over 3 hospitals to phase the implementation across the 3 locations. And then you can also just focus on one phase of care at a time. So start with pre-op, peri-op, and then post-op to limit the amount of stress on your team if necessary. So once you've created this vision, which helps tie back to the values and appeals to your stakeholders, then you have to decide how you're going to define success. And so you come up with a group of measures that tie to that pathway, which include some process measures, which, as Dr. McGinigle mentioned, are not necessarily something you can get easily from VQI. So thinking about your medical record and the ways of measuring those can be helpful, and they can be either direct measurements, for example, when you order a PTOT, or they can be indirect. So a measure of our education was whether the frailty assessment, which we created as a smart phrase, was completed or not. So the other component is postoperative outcomes, and the VQI is a great resource for that. I do think that it's helpful to have in tandem with that some information that you can extract from your medical record, just because the timeline is a little shorter, so that you can provide early feedback to your team about how things are going, and you can assess whether things are going well and they're working out the way you expect. And then finally, I'm a big proponent of including patient-reported outcomes. A big part of ERAS is improving your patient satisfaction. So you can use existing satisfaction measures if your hospital collects those. The downside of that is some of the attribution. So some folks get whole service line patient satisfaction. Sometimes it's hard to know if it's related to their experience in clinic, the hospital. It's hard to know. And it's also difficult to attribute which surgery those patients had and whether it's related to this particular pathway. So sometimes doing specific patient-reported outcomes for just those patients having the enhanced recovery pathway can be helpful. Implementation of that is a whole separate talk. And then finally, an electronic medical record. How can you optimize your both implementation and your tracking of success by using the electronic medical record? I can't say enough, similarly to what we spoke about earlier, about maximizing your existing resources. So if you have a preoperative or postoperative order set, then use that and edit it rather than build a whole new one. And if you can minimize the number of clicks and the interactions your team has by pre-selecting things on that order set, that's even better. You can also piggyback on other enhanced recovery interventions. So example here on the left corner is a nursing flow sheet for documentation of the NPO time and carbohydrate loading drink. And there's other services that are already using this, so we just piggybacked our vascular ERP onto this existing worksheet. And throughout this whole process, communication is key. So I think it's helpful to think about the types of stakeholders you're involving and how that influences the frequency and the type of communication you give them. So I like to put things on graphs. These basically separates your stakeholders into 4 quadrants based on how much they influence the success of your pathway and how much the changes you're implementing affect their day-to-day life. So you can see on the top right-hand corner, or sorry, the top left-hand corner, there's the executive leadership. They're very influential, but to be honest, the changes you're making in your clinical pathway don't affect them from day to day. So the type of communication is generally going to be brief and high level, and you probably don't need to loop them in on a very short-term basis. You can meet with them maybe every other month or even every quarterly as things progress down the pathway. Versus your surgical team, which you can see on the top right, both influential and very relevant to them. You want to meet with them regularly. You want to have multiple different methods of communication, and you also want to come up with a plan for ad hoc communication. How will they contact the appropriate people if they have questions or problems, and how will you respond? So those are different ways to think about your communication plan. And then when you define success, dashboards are great, but it's not enough to just think about, okay, what is our performance on the measures and how is it compared to pre-intervention? You have to think about how you're going to structure your response. So what's your goal? And then once you reach that goal, what's the limit or your threshold for re-intervention or reassessing how things are going? And who's responsible for making sure that we follow up on that in a timely fashion? And how often are you going to look at it as a team and communicate it to the stakeholders that you've already established? So change is hard, and I think it's important to set expectations early. In spite of the amount of work that you put into this, there will be problems. I can attest to that personally. And so oftentimes I think it's helpful just to tell people there will be problems, and this is how we're going to deal with it. If you have questions in the moment, this is how you address it. This is who you contact. And if we don't come up with an immediate solution, we will. So I think setting expectations is key so people don't immediately get frustrated and say, see, it's not working. And communication, as I mentioned, is a big part of that, celebrating your early wins. So even if things aren't going perfectly, you can pick out one or two things where we did do well, send an email after your first patient goes through the pathway and say, good job, we just did this pathway for the first time. It doesn't even have to be a celebration of outcomes. It could be a celebration of process. And if you do encounter resistance, I think that it's helpful to have a framework for how to respond to that. This is a summary of 3 different resistance types by Rick Maurer. And he talks a little, I think the first 2 are the most common. And those really boil down to not understanding why we're doing this or just not wanting to change. And I think that you can address those by either responding to the I don't understand it, by providing or clarifying data, giving examples, and in both cases, whether they don't want to change or they just don't understand the change, appealing to that particular stakeholder and figuring out what motivates them and how it ties into your change, I think is essential. And then the last piece, I don't like you, doesn't necessarily mean you personally. It could be your institution, your department. Maybe they've had bad experience with previous QI interventions that haven't gone well for them. So establishing where that mistrust comes from and then building a relationship around that and being honest about, hey, this is going to be hard, but this is how we're going to support you, I think is helpful. So in summary, enhanced recovery protocols can be a great way to improve patient outcomes and experience. They are complex, and so assessing your readiness can be helpful to assure that your ultimate success. It's not something that I think you should jump into readily. I do think that it's possible to build into enhanced recovery either by phasing your implementation or doing smaller projects around specific issues and then building into a larger pathway. That can be one approach that's helpful. Institutional resources can be really, really valuable, and then setting expectations and communication are key to your ultimate success. Thank you.
I'd like to thank our speakers for an incredible amount of work and effort involved in crafting and fashioning these guidelines for vascular surgery. This is a high-level overview, and I think there is a lot of information embedded within this. I hope you all take a chance to look at the article that's been crafted and published in JVS for this. At this time, we'll open up for questions for approximately 12 minutes. So please come to the microphone and identify yourself.
Hey, great session. I came in a little after it started, so I apologize if this point was brought up. But I'm at UAB with Dr. Spangler and Dr. Beck, and we have some of our team members. There's Z and Courtney are here too. So it really is a team effort as to last approach. And The comment, implementing can seem undaunting because there's a lot of tasks, but the resources, like you said, are there. And whether you maximize or optimize, once you get past that hump, it really does fall into place. And having the ongoing interrogation of your data in real time is just really helpful. I will say when you implement, picking a area where length of stay is already long offers the most benefit. So like we instituted lower extremity bypass first at UAB because that, length of stay was pretty long. And more recently, we just instituted a ERP for amputation. When you get into like EVAR and carotid endarterectomy, which already have a shorter length of stay, the margin of benefit may be a little bit different. But that said, the question I have from a VQI standpoint, do we know either by surveying centers that participate in VQI, which centers are participating currently in ERP and what part of the modules they're, or what areas they're contributing that would align with the module? Because at some point the data query will be helpful within VQI and even submitting through RAC and protecting, the integrity and the of the institution, all the RAC requirements, but to look at length of stay for ERP participating sites versus non-ERP participating sites. So do we know yet where that is? And if not, maybe it's a good time to maybe survey, because I know I can guess which ones are currently participating, but that would be sort of the next step of not just implementing, but at a higher level VQI looking at the data.
Yeah, thank you so much, Dr. Passman, and thank you for volunteering to help me work on this. The short answer to that is yes. It was actually Dr. Jorgensen 5 or 6 years ago who came to me when I very first started talking about ERAS and said, how can we get the VQI involved? And the highest levels of the VQI leadership have been really supportive and excited about enhanced recovery. And we are to the point now of trying to figure out how to operationalize the data harmonization and efficiency of what we're doing in the name of quality for our patients. And one of the elements of an ERAS program, and certainly one of the things that's in every single guideline that's endorsed by the ERAS Society, is auditing of your process measures and your outcomes. And even places who are really centers of excellence in ERAS and do ERAS and have done it for years, when you stop measuring your outcomes and you stop having routine meetings together to review what's going on with your patient data, you kind of stop doing ERAS because there's staff changes and residents or PAs come through and chaos ensues, basically, right? And unless you're really focused on doing the right things, you don't know you're doing ERAS. And so that means you have to do an incredible amount of data measurement, which I don't think is necessarily the burden of VQI data entry people for most institutions. Most institutions are able to leverage their electronic medical record to kind of have these process measures automatically pulled into dashboards. We do something like that at UNC. You can also pay for a service that has all of the process measures that are in the endorsed ERAS Society guidelines, and you can enter the data that way. And so I think every single institution is going to have a little bit of a different way to measure ERAS adherence. And where the true value of the VQI comes in is that we have the one-year outcomes of these patients. And so deciding how adherent do you have to be to ERAS and to be ERAS compliant is the first step. And then for centers that are ERAS compliant, are you actually compliant in each individual patient that you're entering into the VQI? And how do we kind of track that and link these processes at 900 different sites to the VQI outcomes? And so these are a lot of really, really big questions that we've been talking through and thinking about over the last year. And I'm not sure we totally have the answers yet, but the VQI leadership is very engaged in this discussion, and certainly for folks like you at UAB who have a lot of experience with this and with the VQI, we'd love to hear any insights that you have on things that you think may be the most helpful to make sure that we can, leverage all of this momentum and get it into a format that you can use and make actionable.
Hi, Patty Blake, Ohio State. And maybe you touched on this just a little bit, but I wondered, and maybe it'll come like later on during the day, the interoperability between this registry and some of the EMRs. Some of the registries do have that so that the abstractors don't have to pull in all of the information. You just, have an opportunity to focus on certain things, and then you can use that, of course, to create your dashboard. But, a lot of time is spent collecting this data. Mm-hmm. And from my world, I'd rather see people look at the data than spend time collecting the data. So I didn't know how much discussion there was, happening between this registry and some of the EMRs companies to, streamline this a little bit so that we can actually focus a little bit more on process improvement rather than just data abstraction.
Preach it, sister. I don't have the answer to those questions from a VQI standpoint, other than we know it's a really important problem. Dr. Lemon, do you have a comment, or maybe Jim, do you want to add something to answer her question?
We'll have some more information in a session this afternoon.
Fantastic.
And I guess I would just add that while I presented the aortic guidelines, which are what our society endorsed based on the literature, the lower extremity ones, so far we're still a little bit of paucity for some of the literature, and there are going to be recommendations. A number of sites have published on their lower extremity or amputation enhanced recovery protocols, and we would continue to people to publish more to build that evidence base to make stronger recommendations. But in the way that you may find when you talk to sites that have implemented them, the way that power plans or other things are executed sometimes leave more opportunities or fewer for having that data automatically fall out of the EMR. And similarly, and Courtney may be able to speak more to this, but some of the things about mobilization, the way that those are charted from a nursing aspect really needs to have buy-in from the multidisciplinary team of nursing management and nursing's on the floor to make sure it's not creating additional unnecessary documentation in patient care.
One final question on, I'll address this to Dr. Spangler, we're all interested in controlling patients' postoperative pain, and I applaud the multimodal use of analgesia and aesthetics for this purpose. Can you comment on any hesitancy of the use of nonsteroidals, particularly in those patients who may have reduced renal function and creatinine clearance? Has that been perceived as being a problem with using those drugs liberally?
So there are caveats in our detailed recommendations about if there are age or renal function restrictions on the safety of those medications to consider avoiding those, but to still maintain a multimodal approach. So I would say definitely yes, and that as you go towards implementation phases of these protocols, even among surgeons, while we may think that we do relatively similar things, a lot of people have practices that they hold on to dearly. And I remember, especially in lower extremity bypass, the recency of contrast loads for diagnostic purposes or intraoperative purposes. I had concerns about those exact medications, especially in our older patient population. And so I think it's coming to an agreement with your anesthesia team about when those are appropriate in terms of safety restrictions, and understanding that even if they're not safe for a certain subclass of patients, they may still have significant benefit for those that can tolerate them.
I would add as just a closing statement to that these are guidelines. These are not things that you are forced to do. And obviously, you as a clinician looking at your patient and deciding what is best is what you should do, despite what the ERS guideline says. And so, for instance, somebody who has an AKI already, who's going to get a suprarenal clamp, probably shouldn't get the intraoptoidal that they give to all of the hemicolectomy patients, right? But this is common medical sense, and it doesn't mean that you can't let this patient benefit from all of the rest of the ERS elements. And there's a lot of wiggle room. The ERAS Society uses a 70% threshold, and so they want 70% of the patients getting the operation meeting 70% of the elements to be, ERAS compliant, which means that you've got 30% of wiggle room at any given moment to do what you think is right for the individual patient in front of you, which of course is the most important thing.
I'd like to thank the speakers for an excellent presentation on ERAS, which is timely and important for all of us. If you have additional questions, please reach out to any of them during either the break or in the afternoon sessions for that. Thank you very much.